Mm, Hello. Huh. Hello. Am I audible now, guys? Am I audible now? Am I audible now? Okay. Should I start from first question? Should I start from first question? Saiba, should I start from first question? Okay. Okay. So let us start from first question. First question was cleft lip and palate can be recognized in which week of this gestation using transabdominal USG. Okay, and they have given 5 week, 10 weeks, 15th weeks, 20th week. Okay. So there were two studies done. All right, there were two studies done, okay, in which they have studied about in which week of gestation is proper for diagnosing cleft lip and palate. Okay, so they found out week 13 to week 39. Okay, is this range, okay, range of week within which you can diagnose cleft lip and palate, but the mean week what they have proposed is 16th week. 16th week, okay, and in options we have 5th, 10th, 15th and 20th. So closest option to 16 you have to choose. Okay, so closest option is 15th week, so your answer should be 15th week. Okay, just write down this transabdominal USG. Okay, transabdominal USG can be used for diagnosis of cleft lip and palate. Okay, cleft lip and palate, and in which week? 16th week is the proper, you can say, mean week, and the range of week is 13th week to 39th week. Okay, so just write down these important points over here. Okay, yeah. Moving on to the next, which is clinical based question. Okay, a patient reports with a reddish brown permanent incisors and primary teeth. Okay, so there is a pigmentation. Okay, reddish brown pigmentation. Mother remembered no history of tetracycline during pregnancy. So most common cause is tetracycline consumption during pregnancy. Okay, the teeth becomes brown, right? And she did not have any tetracycline tablets, but she remembered sickness in childhood. Okay, the etiology for discoloration can be, okay, now here we are talking about intrinsic discoloration. Intrinsic discoloration. So there are many causes for intrinsic discoloration, right? So one of the cause is metabolic cause. Okay, metabolic cause. So I'm just going to give you important points to be remembered for your INI exam, right? So metabolic cause, there are some neonatal, you can say, diseases which causes hyperbilirubinemia. Okay, so there are some diseases which causes neonatal hyperbilirubinemia, right? Hyperbilirubinemia. Okay, now what does hyperbilirubinemia means? there is increase in bilirubin pigment, right? And during the developing stages or developing stage of the tooth, what happens is there is an incorporation of this bilirubin pigment into the developing hard tissues, giving tooth some color, right? So now where there is a hyperbilirubinemia, bilirubin pigment will incorporate and will give something like a yellowish green tint, yellowish green tint, right? And this is called as chlorodontia. You can just write down this color, chlorodontia. All right. And which diseases cause this hyperbilirubinemia? Just write down the names of those disease. Okay, so if in option you have these names, you can just mark the answer correct. So we have sickle cell anemia, okay, in which there is hyperbilirubinemia and can cause yellowish green tint to the teeth, right? Sickle cell anemia. Then we have thalassemia, okay. Then we have hemolytic disease of hemolytic disease of newborn newborn due to Rh factor. You can just write down the disease, right? Disease names. Then we have atresia, biliary atresia. Then we have bile duct destruction, or you can say bile duct malignancy involving bile duct, or you can say bile duct obstruction also. Okay, then we have biliary hypoplasia. Biliary hypoplasia. Now, in these diseases, we have hyperbilirubinemia. All right. So, if the infant is affected by these diseases, he this can impart yellowish green tint to the teeth, right? And that is called as chlorodontia. Moving on further, what we have is reddish brown teeth. Reddish brown teeth. So in question they have asked about reddish brown pigmentation, right? So reddish brown pigment can occur due to porphyrin metabolism. So disturbance in porphyrin metabolism, okay, can cause this reddish brown pigmentation to teeth. Okay, and this occur in which disease or which entity? Congenital, congenital erythropoietic, congenital erythropoietic porphyria, porphyria, right? So this is called as Gunther's disease, Gunther's disease. All right, Gunther's disease. Now, porphyria is used like a pigment, okay, which is used to make up heme, right? So there is a disturbance in metabolism of porphyria, and excessive, you can say, porphyrin pigment is being secreted, right? And that will get incorporated into the heart tissues, developing heart tissues, giving reddish brown color, right? And porphyrin pigment, to be specific, have affinity for calcium sulfate, right? Affinity for calcium. So it is incorporated into the teeth more, you can say, like in more amount, okay? Compared to bilirubin, this porphyrin has got affinity for calcium sulfate, so it is incorporated more commonly. Okay, and this is called as erythrodontia. There we have called that as a chlorodontia. This is now called as erythrodontia, giving reddish brown color to the teeth, right? All right. So, what should be your answer here? We have reddish brown pigmentation. Your answer should be option D, Gunther's disease, okay, which is congenital erythropoietic porphyria. All right. I hope this is clear. Okay. About intrinsic discoloration, you just need to remember these some diseases and the pigmentation it causes. All right. Coming on to the third question, match the following lesions with their radiographic appearances. Okay, now this should be easy. We have discussed this in class. Okay, so radiographic appearances they have given in column 1, and then we have to match it with the proper tumor or proper, you can say, cyst. Okay, so first is soap bubble. Soap bubble appearance is seen in which entity from here? Okay, so we can take the ameloblastoma, right? B. So first resembles, or you can say soap bubble appearance is seen in ameloblastoma, right? Second is what? Unilocular anteroposterior lucency. Unilocular anteroposterior. Now, which you can say entity extend anteroposteriorly, okay, which does not cause buccolingual expansion. Which entity is that? Only one entity among these, which is OKC. Okay, so second resembles B, okay, or matches B. Then we have tennis racket pattern. Tennis racket pattern is seen in which entity? You all should know this. Odontogenic myxoma. Myxoma shows tennis racket pattern. So third matches with A, which is odontogenic myxoma. All right. Then we have onion pill appearance. Onion pill appearance seen in which entity among these? Ewing sarcoma, right? Ewing sarcoma. So fourth will match with E. All right. Then we have fifth, sun-ray appearance. Sun-ray appearance is seen in osteosarcoma. So 5F. Okay. And the remaining one is dentigerous. So, so bubble appearance basically seen in dentigerous also sometimes. Okay, not commonly seen, but sometimes. So you can just incorporate that into soap bubble. Okay, so what should be your answer here? Option B should be your answer. Okay, so first matches to C and D, second B, third A, four E, and fifth F. Right? This should be easy, right? Once you know all the appearances, this should be easy. Coming on to the next question. This radiograph denotes what phenomenon? Okay, so as you can see over here, this tooth looks somewhat abnormal, right? So that is a bend, okay, or curve, okay, along the length of the along the length of the tooth, right? And most commonly, the bend or the curve is seen along the root. Okay, and this phenomenon is called as dilaceration. Dilaceration. Option C is the correct answer. All right. Now, I have one more important point in this dilaceration. Whenever the root is dilacerated buccally or lingually. Now here it is say angulated like mesially, right? Distally, right? So it is angulated distally. But whenever the root is angulated or dilacerated buccally or lingually, you can see somewhat this appearance. This appearance. Okay. So there is a radiolucency outside this, and there will be centrally there will be a radiolucent or shadow. Okay, that is called as apical foramen, and the radiolucency surrounding it, as you can see over here, radiolucency surrounding it is a PDL space, right? So whenever this dilaceration dilaceration is buccal or lingual, you can see this bull's eye appearance. You can just write down, very important, bull's eye appearance. Okay, bull's eye appearance seen in this dilaceration of the root buccally or lingually. Okay, moving on to the next question. Which crystals are used in transducers used in USG? Okay, so this is very easy factual question. You should know which crystals are used in USG. So we use transducer in USG, right? Transducer, or you can say uh, uh, this, yeah, transducer. And the transducer uses which crystals? Piezoelectric crystals. Piezoelectric crystals. Okay, so we have transducer. This transducer uses piezoelectric crystals. Okay, and more commonly used piezoelectric crystal is lead, zirconate, titanate. Lead, zirconate, titanate, right? So, what should be your answer? Option A should be your answer, right? And USG, the other important points related to USG. USG uses non-ionizing radiation, right? Non-ionizing radiation. Then it uses this diagnostic USG uses this frequency ranged from, you can just write down these important point related to USG. First, non-ionizing radiation. All right. Second one, this diagnostic USG uses the vibratory frequency in the range of vibratory frequency in the range of 1 to 20 megahertz. 1 to 20 megahertz, right? And this basically works on the phenomenon of echo, right? So sonic waves, when you move the transducer over the area to be radiographed, okay, this sonic waves goes and hit the tissues, and echo comes back, right? Echo comes back, which is again taken up by this transducer, and then it is processed, and images are shown on the screen, right? Now, this phenomenon, current advanced techniques allows us to take up these echoes at very rapid rate. Okay, therefore it is also called as real time imaging. So when you want to say do USG of TMJ, okay, so you can do USG in open and close position. Okay, so there are echoes which are created at rapid rate. Okay, so the movement of TMJ or the condyle, the joint, can be recorded at very rapid rate. Okay, so therefore it is called as real time imaging, right? So it permits echoes to be processed at rapid rate. All right, okay. Yeah. So these are the important points about USG that you need to remember. All right. Moving on further, question 6. Okay, a 52 years, this is very easy. We have seen it many times. a 52 years old known case of psoriasis comes to you for routine dental checkup. When you find this non-scrapable condition on patient's tongue, what is your diagnosis? When you look at this condition, okay, you have the serpentinous areas or serpentinous white lines, right? And these are nothing but what? Geographic tongue. Geographic tongue. Okay. Now, here they have not directly given geographic tongue, but they have given synonym of it, right? So geographic tongue is also called as wandering rash, is also called as erythema migrans, right? It is also called as benign migratory glossitis. So you should know all these synonyms of geographic tongue. So you can just write down erythema migrans, benign migratory glossitis, wandering rash. Okay. So what should be your answer here? This erythema migrans. So there are the areas, okay? There are multiple well demarcated areas, okay? Erythematous areas. And this erythematous area, what it suggests the atrophy of filiform papillae, right? Atrophy of filiform papillae. And surrounding it, we have these white margins. White margins, what it imparts? It suggests the regenerating filiform papillae. So erythematous area, atrophy of filiform papillae, and surrounding it we have white margin, which tells us regenerating filiform papillae. Okay, and these lesions changes. Okay, this do not like this appearance will change. Okay, so this rash or this lesion is wandering all the time, therefore it is also called as wandering rash. All right. Okay, and the most common site which is affected here is anterior two-third of dorsum of tongue. Anterior two-third of dorsum of tongue. Okay, and you can say this lesion is asymptomatic commonly, but whenever patient have this burning sensation, you can give this symptomatic relief, okay, to the patient by giving the benzocaine mouthwash or lignocaine gel to be applied, okay, onto the tongue. All right. Moving on further, we have, okay. So this image is diagnostic of which of the following condition? So this here, what you see here is blanching or white, you can say marble like mucosa, right? And here they are checking what? The mouth opening. So mouth opening is also reduced. Okay. So we have keywords here. By looking at image, you can see blanching of mucosa, and you can also see reduced mouth opening. Reduced mouth opening, right? This indicates what a disease? This indicates OSMF. OSMF, oral submucous fibrosis. Now you have the keywords in OSMF. Blanching is one, or you can also say marble-like mucosa. Marble-like mucosa. All right, marble-like mucosa. Then you have reduced mouth opening. Then again you have hockey stick shaped uvula. Okay, so these are keywords. Whenever they give you clinical based question, you have these keywords. You can just diagnose the condition as OSMF, right? So hockey stick shaped mucosa. Then we have fibrosis. Fibrosis again. Fibrous bands are palpated. Okay. Then you have something called as uh yeah, mucosal. Yeah, mucosal texture will be leathery, somewhat leathery mucosa, right? Just write down keywords for OSMF so you can just go with this diagnosis of OSMF. So actually what happens, OSMF is chronic disease, okay, inflammatory disease, and areca nut chewer or betel nut chewer gets this condition, right? chronic betel nut or areca nut chewer. So the you can say the constituent in the areca nut or betel nut is arecolin. Choline is responsible for excessive collagen deposition, okay, collagen formation, and due to which what we have is decreased vascularity. Okay, there is excessive collagen formation here, there will be decreased vascularity, and therefore we see mucosa like this. Blanching is there due to reduced vascular supply. Okay, then we have fibrous bands because of excessive collagen deposition. There is fibrous bands. When you palpate the mucosa, you will feel the fibrous bands, right? And in advanced stages or severe stages, patient will not be able to open mouth. Okay, normal mouth opening is not possible. Mouth opening will be reduced, and then you will see this um, um, limited movement of tongue also, and hockey stick shaped uvula. Okay, so these all are the features of OSMF. All right. Okay. Moving on further, yeah. Question 8. A 52 years old patient under retroviral therapy, like HIV or AIDS patient, presented with a complaint of nasal regurgitation of food, right? Examination revealed palatal perforation as seen in color play. Okay, this is palatal perforation. Microscopic examination reveal large non-septate hyphae with branching at obtuse angle. Now they have given microscopic examination, histopathological examination, and they have clearly mentioned this non-septate hyphae have been noted, right? And they are branching at obtuse angles. Now, uh, since they have mentioned hyphae, so we have the diagnosis as fungal infection. So this should be a fungal infection. But in option, they have given four types of fungal infection. So what should be our answer here? Okay. Now I want you to note down the microscopic examination or histopathological examination for mucormycosis, right? And aspergillosis. Aspergillosis. This description what they have given here resembles the mucormycosis fungal infection, and mucormycosis is also called as phycomycosis, right? So here the answer is option A. Okay, because we have palatal perforation also. And what happens in mucormycosis, there is invasion. Okay, there is tissue necrosis. Okay, tissue necrosis. So fungal or fungus invade into blood vessels. Okay, they cause thrombosis and then tissue necrosis. And then we have different, you can say, forms of mucormycosis, and we are concerned with rhinocerebral form here. It starts with oral cavity, invade into nose, invade into brain. Like may cause death also. Okay, so what are the features that you see in rhinocerebral form? These. So nasal congestion or discharge. Okay, then facial numbness in severe cases, blurry vision when eye is also involved, nasal discharge, nasofrontal headache. This whole part, okay, will have a pain, ocular pain, fever, diplopia, chemosis. So these are some, you can say, features that we see in rhinocerebral form. So they might give you a symptom like they have given here, nasal regurgitation of food, right? Due to this palatal perforation, there is nasal regurgitation of food, right? Palatal perforation is due to fungal invasion. And the microscopic examination describes this mucormycosis or phycomycosis. Now, aspergillosis, if we talk about aspergillosis, what is the microscopic examination or histopathological examination in aspergillosis? There is thinner septate, okay, thinner septate. Then we have regular branching, regular branching, and at acute angle. Related to this description given in microscopic examination, I've just compared the mucormycosis and aspergillosis. Next time, if they ask you thinner, septate, regular branching at acute angle, your answer should be aspergillosis. Okay, but the branching at obtuse angle and non-septate hyphae, then your answer is mucormycosis or phycomycosis. All right, this is about fungal infection. Moving on to question 9. Yeah, very easy. Floating tooth appearance is seen in which of the following condition? Floating tooth appearance. We have seen it multiple times. We have discussed this. Okay. So floating tooth appearance, first basic chronic periodontitis. Chronic periodontitis, right? Chronic periodontitis. Next we have cherubism, right? Cherubism also shows floating tooth appearance. Cherubism, we have bilateral multilocular radiolucency, right? Then we have malignancy, of course, malignancy invading into bone, right? Then we have histocytosis X. Now, in place of histocytosis X, they might give you Langerhans cell disease. Okay. Now, in Langerhans cell disease, also we have three forms. We have three forms. Okay. So we have eosinophilic granuloma, lateral sieve disease, lateral sieve disease, and then we have hand Hand-Schuller Christian disease. Hand-Schuller Christian disease. Okay, so floating tooth appearance is seen in all these entities, and among given options we have cherubism. Yes, it is seen. Malignancy invading into bone. Yes, it is seen. Histocytosis X. Yes. So your answer should be option D, all of the above. So, floating tooth appearance is seen in all of the above, and this is seen due to like what cause? There is alveolar bone destruction around the teeth, right? That gives this floating tooth appearance, right? Destruction of alveolar bone. All right. Okay. Moving on further, we have, yeah, last question. Interpret the following radiograph. Now, here we have this radiolucency, okay, inside this root, okay, inside this root, okay, which uh, y- you can interpret or diagnose this condition. Okay, now among given option, what do we have is dens invaginatus, B internal resorption, C dens invaginatus, and D Tellin's cusp. To answer this question, you need to rule out the other entities which are wrong. Okay, so starting with dens invaginatus. Okay, so dens invaginatus, if you see this Euler's classification, okay, this is basically invagination of enamel organ into dental papilla, right? So, invagination of enamel organ into dental papilla, right? So, we have classification based on how much is the invagination. Okay, so up to CJ, beyond CJ, and along the whole length or root. Okay, so in, you can say, in the radiograph what you see here is, you will see this tooth within tooth appearance, tooth within tooth. So here if you can see clearly, you can see this inner something abnormal inside this tooth, right? This is dens invaginatus, so tooth within tooth, or dens in dente appearance. Okay, all right, so this is dens invaginatus. Now we have dens invaginatus. What is dens invaginatus? It is like a accessory, you can say, pulp, accessory cusp, you can say. or you can say pulp extension into the tooth. Okay, if you can see it clinically, you have this extension, right? Extension, it's like a accessory cusp only, right? And the pulp will extend into this accessory cusp. All right, and radiographically you will see something like this. Okay, this pulp has been extended up to here, right? This is evaginatus dense evaginatus, right? It is emerging out. Okay, next option that, yeah, this is just to give you a difference between these two. Dense invaginatus, this pulp horn is extending into this cusp, right? And invaginatus meaning this enamel organ will fall into the dental papilla. So depending on how much is the level of invagination, we have classification, right? Okay, now we have talens cusp. Now talens cusp is what? Talens cusp is the accessory cusp. Okay, accessory cusp, and it is mostly seen in relation to anterior teeth, right? And maxillary teeth, most commonly involved, anterior teeth. And radiographically, what you see is this cone shaped, or you can say radio opaque structure. Okay, radio opaque structure like this. So talens cusp, all right. And now, difference between talens cusp and dense invaginatus. Dense invaginatus is also called as Lyon's premolar. So, premolar is most commonly involved tooth, and in dense invaginatus, you have this anterior teeth, maxillary anterior teeth, which are mostly involved, right? But now, here coming on to our question, among these, what do you think is our diagnosis here? So, our diagnosis is option B, which is internal resorption. This is not dense invaginatus, this is not dense invaginatus, not talens cusp. This is internal resorption, where you will see radial lucency inside this tooth. This is idiopathic, okay? No, you can say a cause, idiopathic or unknown cause for this internal resorption, right? So here we complete 10 questions of oral medicine and radiology. I hope you all have understood the important points, and you can just go with this. You can just remember these important points related to these questions. All right. If you have any doubt, you can post it in the group, right? All right, guys, we can conclude this session, and I hope you all understood this important, you can say, points, and just, yeah, see you in GT3 discussion. Bye.